So, sir, regarding if we talk about the prevention part of cardiovascular segment. So nowadays there is a concept of is the prevention is always better than cure, and now it's now very aggressively that from a physician perspective and as well as from the different kind of the pharmaceutical companies are also promoting this kind of the prevention concept. So regarding this prevention of cardiovascular disease, what is your key opinion on this particular segment, sir?
If you see in cardiology, if you see the way acute anterior myocardial infarctions have changed, if you see over the last 30 years, the acute anterior myocardial infarction numbers have plummeted. In the West, in India and China, it is increasing. But even over a period of 10 years, we expect these numbers to plummet. So in terms of cardiovascular disease, acute myocardial infarction, chronic stable angina, all these diseases is going to plummet. If there is any two segments which is going to grow over the next decade or so, is two conditions. One is atrial fibrillation, another is heart failure. These are the two epidemics, I would say, of the next generation or next decade or so. So these are the only two. If you say analyze the American data, you will clearly realize that there are only two epidemics which are growing, and that is atrial fibrillation and heart failure. Part of it is due to the aging of the population, and part of it is due to the fact that people are surviving longer. So people don't die of MI immediately. They survive, then they develop heart failure over a period of time, and that leads to a whole set of conditions. So if you were to look at prevention in cardiology, the future of prevention revolves around these two scenarios, that is atrial fibrillation and heart failure. Because with respect to coronary artery disease, we have almost, I am not saying we have reached the peak in India, but at least worldwide we have reached close to the zenith. We have reached a point where whatever maximum could be done in an acute myocardial infarction is already being done. So we are already meeting the so-called goals, or get with the guidelines concept, and we are already reaching targets. If there is two areas where we need to do something, there is atrial fibrillation and heart failure.
So it's very well said. The AF and CHF both are one of the, now it's a next era, what we can say, it's a last era, what we can say, it's a cardiovascular disorders, metabolic disorders like diabetes. But now the recent researches and even guidelines are also now focusing on these two conditions regarding atrial fibrillation and heart failure. Now if we talk about the atrial fibrillation and its prevention, but still if global incidence rate, if we are talking, it's around 1.8 to 2%. So it seems to be under detected, and that's why definitely even the government, all the governments are also now proposing this kind of the awareness of regarding atrial fibrillation. So what is your opinion on this particular disease, that how can we increase the more and more incidence of
this whole concept of incidence is very frivolous.
Yes.
When you are in school, you are taught one proverb: the eye only sees what the mind knows.
Yes.
So very often, many physicians also see patients with atrial fibrillation, they don't recognize.
Okay.
So forget about knowing the incidence in the general population. Even in patients coming into hospital, patients walking into a clinic, when they go a routine ECG and find an atrial fibrillation, hardly anybody detects it.
Yes.
So forget about knowing the prevalence in the community. Even in people who come to hospital, which is a high risk subset, even in that subset, when you are not picking up things, forget about all these numbers I personally feel wrong. The reason is we don't have a very systematic way to evaluate. In fact, see, I have been into practice for the last 10 years. So in 10 years, I have seen AF to a tune. I feel as if I have been practicing cardiology for 40 years.
Yes.
That means, as per prevalence, the prevalence we are missing out almost like 4 times.
Okay.
So we have seen so much of AF. So it is very wrong to generate data from West and say that our prevalence is low. I don't believe it. We don't see. We see ultimately, coming back to my starting statement, if you do not know, if your mind doesn't know, if you don't have the keenness to look out for atrial fibrillation, I'll put in a simple question. You go and ask 100 neurologists today and ask them how many people you have consciously looked at AF as a probable etiology of a stroke.
Yes.
And I can assure you, after 100 neurologists, more than 80 to 90% will say we never thought of it.
No. Okay.
Some of them would have referred to a cardiologist, and the worst part is, after being referred to a cardiologist also 50% of the time would have done a transthoracic echo, done a transesophageal echo, and stopped at that level.
Okay.
You will never find a cardiologist in any center looking prospectively at every patient who has had a stroke to rule out whether there is a possibility of underlying AF, which itself says the true story. See, forget about general population, people visiting the hospital, people presenting with stroke, even in them we are not aggressively looking for AF.
Okay.
So how can you say the incidence of AF is low? It is the fact that we are not looking at it. That is a sad truth.
So whatever the number is there, actually it is not actual number.
You know, it is not, it is just like this. It is, I will put it in simple words. If I open my eyes at 10 o'clock in the morning and say sun rises in the morning, it's something like that.
That's very well said. So if we talk regarding atrial fibrillation and its complication, the stroke is one of the major complications when there is atrial fibrillation. You also said that when the stroke is happening, then you have to go the retrospective to find out the underlying cause is atrial fibrillation. But now even the data is also saying that even when patient is diagnosed with atrial fibrillation, there is not aggression is also seen in the physician's level that to treat the patient for prevention of stroke. So what is your experience on this particular concern as well?
The thing is very simple. At any point of time, any therapy, there are three issues involved. One is called the cost benefit ratio, second is called the risk benefit ratio, and the final thing is cost risk benefit. So when it comes to atrial fibrillation, the biggest challenge faced by a physician is when you tell the patient that the risk of bleeding or the risk of treatment is almost parallel to the risk of benefit. When you put people on a warfarin therapy or things like that, tell me how many patients would be convinced. Forget about the cost. Cost comes later into the equation. You start off telling patients that you have a problem, I will give you a treatment. This treatment may prevent the problem, but may create another problem and may not still prevent the problem. If you make such a statement, tell me after 100 patients, how many will willingly take treatment? You know, that's the problem. See, when you put the whole thing in a picture, holistic way, you look at the patient, you talk to them, you tell all the risks, you tell all the benefits, then itself it becomes a challenge. Now you, on top of it, put the burden of cost. Then technically you have ruled out any therapy. And somehow down the line, I've seen how patients are treated in US versus people are treated in India. Somehow in India our treatment is reactive. That is, we prefer to do something only after something happens to us, or in your language we would call it as secondary prevention. But in US the concept is of primary prevention. So in India it is very, very difficult to even for doctors to understand the philosophy of primary prevention. So forget about patients. If doctors cannot be convinced about primary prevention, and there are so many hurdles in secondary prevention, that primary prevention looks like utopian dream kind of thing. That's the problem.
That's definitely, it's a real world kind of the scenario as of now in India as well. So if we talk about the management part of a stroke, for the definitely primary prevention as well as secondary prevention, the various antithrombotics are available since aspirin, warfarin, now the newer generation has also raised up. So you have passed through all the phase of all the three drugs. So what you have found the advantage and also the challenges with the older versus newer generation?
See, if you forget about NOACs, if you discuss pharmacology in general, this has lot of analogy to the gliptins in the market also. 25 years back when I joined medical college, the concept was for more powerful and powerful drugs. Okay. So if tablet A is having this much effect and tablet B is having double the effect, immediately tablet A goes out of the market because you have a drug which is tablet B. Gliptins and NOACs are the two classical examples of newer drugs where we are not talking about efficacy, we are talking about safety. So we have come to a scenario where we have started telling people that this drug is less effective but more safe. And this concept not only sells today, is the flavored theme of doctors today. So we don't want more and more powerful drugs, which was there 25 years back. As a medical student, I used to think that more and more powerful drugs. But today I am looking at not more and more, I am looking at drugs which I appreciate will be less powerful. I appreciate will not be as effective as the other drug. But if you assure me that it is going to be more safe, then I am ready to take it. The gliptins are proof of it. It's like 1,000 crore brand in India. The reason everybody in the field of diabetology knows that gliptins are the weakest new drugs to hit the market. But they are growing simply because they have promised us safety. So same applies to NOACs. Now you put the ball in NOACs court. NOACs have never been proven to be superior to warfarin. But the beauty with them is they are offering us the benefits of safety, of compliance, side effect, drug interaction, all those things. Not a single NOAC has won the argument of efficacy. But almost all NOACs across the board have won the argument of safety to an extent. Maybe some of the drugs have failed in that safety test also, but in general most of the NOACs have won that argument, and that's why today NOACs are so popular.
Okay. So definitely the newer generation oral anticoagulants, they have some advantage as compared to the challenges of the vitamin K antagonist. Now if you go deep inside to the NOACs part, as of now in India the rivaroxaban, dabigatran, apixaban, these 3 drugs are available. So how you will customize your patient according to the drug, means how will use this drug in various kind of the patients. Suppose this drug has no any head-to-head trial, no comparative data individually, means in with each other. So how will you select that this drug can be used in this patient, this drug can be used in this group?
See, I know I should not compare this to real life, but in real life also very often we have a concept called as first come first serve basis. Okay. So if you go back to our experience with NOACs, the experience with NOACs is almost like 5 to 6 years now. So obviously since dabigatran was the first drug to be launched, so we had huge experience with dabigatran. Like I can confidently say that more than 400-500 patients of mine are on dabigatran. So that's a huge number when you compare with other NOACs. So definitely dabigatran has a huge lead over all the drugs simply because they were first to hit the market. So that advantage with dabigatran will persist at least for the next 5-6 years if I am not wrong. So that lead will always be there. The dabigatran was the first to be introduced, for the first to show safety, the first to show efficacy. And if you look at dabigatran data with 150 mg, that is a very robust data looking at efficacy over warfarin. Till date you have never had any NOAC showing superiority over warfarin in any trial. So dabigatran for that matter has been very specific in showing a slight superiority over warfarin in the 150 mg. But believe me, of my patients who are on dabigatran, most of them are on 110 mg. I'll acknowledge that also. But if you look at the data, definitely 180, 150 milligram is really in like top of the charts and has shown a real good benefit over warfarin. So that I feel is the biggest argument for dabigatran. The arguments against dabigatran revolve around other issues that from day one there has been some controversy with respect to myocardial infarction with patients with pre-existing coronary artery disease, with patients with pre-existing renal failure, and more importantly in patients with acute coronary syndrome. And more often as a practical, if you are the patient or I am the patient, any drug which is given twice a day always is a challenge in terms of compliance. Other than these 2 issues, I think dabigatran is the leader in the field. Rivaroxaban appealed to everybody because of the Rocket AF data, which showed a sincere superiority in terms of safety. I would not say that Rocket AF proved that rivaroxaban is superior to warfarin, but at least when it comes to the safety data, I think the safety data of rivaroxaban is very good. And I feel the big clenching point about rivaroxaban has been its safety with respect to myocardial infarction. So what happens is at the end of the day I am a cardiologist. So my bread, butter, jam, everything revolves around ACS. So to use a drug, see I can always say that the dabigatran data on myocardial infarction is tricky, but at least I can confidently say the data on rivaroxaban is so strong that I can say that even if it doesn't cause MI, it saves more patients. So it is not dabigatran. At the end of the day, I will say it is neutral. Whereas rivaroxaban, I will confidently say it is more positive. That is, rivaroxaban shows a definite data in terms of positive benefits in patients with IHD. So today I would be choosing rivaroxaban in all patients whom I have a combination of IHD with atrial fibrillation. So I have stented a guy and then I need to treat his atrial fibrillation, I would strongly think about it, because I am not saying apixaban is bad in IHD, but if you see the data on IHD, the only drug which shows a real good benefit in terms of risk reduction and mortality and all those issues within the, no other drug comes closer to rivaroxaban. Apixaban, I would still have some reservations, because I would call it the latest baby, or the new baby on the block. So data is coming up. I am not saying data is not there, is coming up, but not as robust as rivaroxaban and dabigatran. Okay. So I am still little concerned about starting off apixaban. To put it in a nutshell, if you were to analyze all my patients, the least number of patients would be on apixaban. Maybe I would say in double digit. Okay. So rivaroxaban maybe more patients, maybe 100 odd patients, but apixaban definitely not in double digits, not more than that. So because it's a new kid on the block. One of the key things I have noticed about apixaban is in terms of safety in older people, I think it scores slightly above the other two drugs. Okay. So maybe if I am considering as a 80-year-old female with the borderline renal function, I think I may choose apixaban. I would rather wait. See, like I told you about dabigatran and rivaroxaban, I have always waited. Okay. So I am a strong believer in the philosophy, never be the first to start a drug.
Yes.
Okay. So somehow I always believe that you should let the the evidence distill down to clinical practice before you using it. With dabigatran, I have a clarity of mind. With rivaroxaban also I have a very good clarity of mind that these are the scenarios where I am going to look at rivaroxaban and use it in particular patient. With apixaban, I am optimistic. I am not saying that I am. See, when you compare it with edoxaban,
okay,
I know edoxaban is going to be dumped. That's my gut feeling. Maybe the company may think. I personally feel edoxaban may be dumped, but apixaban is not in that category. I feel that apixaban will give a good run to these guys, especially in a select group of people.
Surely. So definitely sir has given very in detail description and regarding the practical challenges as well, that atrial fibrillation definitely as of now whatever the number is, that it's totally maybe under detected. So there is no assurance regarding that, because the sir has said very clearly, when we open the eyes, then definitely what we can see, that is our belief. So that's why it's very actual registry and actual incidence rate to find out regarding the atrial fibrillation. It's very difficult task. Second thing, what he told regarding older oral anticoagulants regarding the VKs, they have very practical challenges like the monitoring and drug-drug interaction. So and to convince the patients regarding on that, it's also a very difficult task. And in depth, what we have discussed regarding NOACs, newer generation of oral anticoagulants, that's from the first drug like dabigatran, then rivaroxaban, and followed by apixaban, and how we can utilize the each and every drug in individualization of the patient's treatment. It's very well discussed. So with this note here, sir, we are ending our discussion, and sir, thanks a lot for your providing your time and your all the valuable opinions.